Chronic pelvic pain disorders affect a large number of women of reproductive age. They are a common cause for women to come see a gynecologist because many of the underlying reasons for such pain involve the reproductive organs. Unfortunately, chronic pelvic pain is a vague condition, and the differential diagnosis includes all of the other potential tissues in the pelvis, whether it's the bladder or the bowel structures, musculoskeletal causes, or nerve conditions. In fact, a recent survey of OB/GYN residents revealed that a majority of respondents feel overwhelmed by the chronic pelvic pain patient. And that's seen similarly in attendings, likely due to the high level of complexity presented by these patients. In our practice, we think it's critical that a detailed history and physical exam serve as the foundation for getting the right diagnosis as early as possible. Indeed, as you will see later, we'll look at how to get a proper history to try to optimize chronic pelvic pain evaluation and thereby reduce the complexity for a clinician. Over the years, I've come to really appreciate how building a strong patient-physician relationship is crucial to effective management of patients with pelvic pain. A core tenet in building this relationship is actively establishing rapport. That may not come naturally between two strangers in a brief window of time, but there are some simple suggestions that have been tested and can facilitate this. These include use of attentive listening, being comfortable with offering sympathy or support using nonverbal signals, having good eye contact instead of looking at a computer, and engaging each encounter with genuine concern. These are probably just reminders for most of us, but they are oftentimes forgotten due to the pace of modern medicine. Active listening is a crucial part of the patient-physician encounter and in relationships in general. Listening is essential for promoting rapport, but certainly it also fills some operational needs in the clinic. We have to listen to be able to get the right data, what a patient has tried in the past, what their diagnosis has been in the past, and what are treatments that have either not worked well or maybe worked to a limited extent. For some patients, simply being actively listened to provides genuine social support. Perhaps most importantly, a patient who knows they're being listened to is more likely to view their relationship with their doctor as an alliance. All of these factors may help distressed patients cope with their condition and are likely to promote optimal results for treatment. The patient visit consists of many key components that should not be overlooked. First, allow adequate time for the initial encounter. On average, I spend between 45 to 60 minutes for anyone with chronic pelvic pain who is new to my practice. Not everyone can do this, but if you're committed to helping this important group of patients, it's well worthwhile, even if you have to break it up into 2 visits. We can all relate to the time constraints clinicians have on a day-to-day basis. This is where utilization of team extenders can play a significant role. For example, leveraging a nurse or highly trained medical assistant to ask some of the initial standardized history can reduce the total amount of time of passive work by the clinician. Much of this can be standardized with a well-developed checklist. So what happens when the patient does not come bearing all of the critical information we need, such as operative reports or path reports? I suggest utilizing a quick follow-up visit, which I typically schedule for about 20 additional minutes in order to complete the plan. In the interim, if a patient needs some pain relief, I might provide a variety of non-opioid analgesics and request they come back with their medical and prescription history so that I can get a full sense of the scope of their disease before doing additional prescribing. The International Pelvic Pain Society has an assessment form that can serve as a good starting point. This assessment includes detailed questions related to pain symptoms, such as how would you rate your pain with sexual activity, which is evaluated on an 11-point scale, with 10 being the worst pain imaginable. The International Pelvic Pain Society assessment form is comprehensive, so time constraints could limit its completion during a patient visit. Sometimes it's better to mail it out ahead of time or give it in the waiting room, with a suggestion that the patient arrive a little earlier. I do find the following 5 main questions particularly helpful. Do you have painful periods? Do you have daily pelvic pain? Do you have pain with sexual activity? Do you have pain upon urination? And do you have pain with bowel movements? Because of the complex and nonspecific nature of pelvic pain, it is also critical to understand its origin to avoid misdiagnosis. Screening for gynecological, urological, gastrointestinal, musculoskeletal, neurological, and psychological aspects of health must be performed at some point to get the best picture. Sometimes a patient has pelvic floor spasm, or they have chronic bladder sensitivity that could feel as if it was coming from the uterus. Now, let's meet our patient.
As a patient, when I approach a new doctor, there's a certain level of anxiety. Will they validate my experiences? With this interaction, I think Dr. 2 asked a lot more personal questions than I'm used to, and that really put me at ease, and it made me feel like he understands a huge impact that this disease has on every aspect of your life. I think that's often missing when you're interacting with a new doctor or even an existing doctor. Also, he showed a lot of empathy, and I think he asked good questions.
After 5 to 10 minutes of talking with a patient, or maybe a little bit longer, I'm hopeful that I've gotten a sense of what their goals are for the encounter. But just as important is their concern about the associated issues with their sex life, or how much it's affecting, in Shauna's case, their activity levels, which bring meaning to their lives. Unless you plan the data gathering carefully, for complex histories, you may not be able to catalog every possible medication a patient has taken, because they may have to research this a bit and get back to you. However, very important areas to look at are medications that had the most side effects in the past, or those that may have worked particularly well in the past. It's the same with procedures. I find it's also essential to explore health aspects we aren't necessarily trained to look at, such as social support. This logically follows if the interview is intended to get to understand your patient's needs.
From my perspective as a patient, I need to keep all my reports organized so I can bring them when I see a new doctor. Being prepared helps avoid that initial stress that I have that the doctor won't believe me, or that I have to convince them that my pain levels attend all the time, which has happened to me in the past. Then, when I give them multiple operative reports, including images, it changes the dynamic of the visit. I think it speeds up the process of establishing a better relationship between me and the doctor. Often, when we go to doctors, we're looking for a final, definitive solution that they probably can't offer us. Even so, we need to be fully aware of the medications we're on, and we need to read the operative reports. It's my body, and I'm a specialist because I'm the one who had to live with it. I know all the quirks, so I think it's useful to have the information on hand.
In summary, the patient history is the foundation for the physician-patient relationship. During the patient encounter, it is important to build rapport, and it is critical to spend adequate time with the patient. Remember to ask the patient if she has painful periods, daily pelvic pain, pain with sex, pain with urination, or pain with bowel movements. I hope this brief video about obtaining a proper patient history is helpful in your clinical practice, and I thank you for your attention.